going to demonstrate the placement of a W-goat excluder for a fairly straightforward aneurysm. You don't often see them like this. Bottom line is both wires have been placed up into the descending thoracic aorta. They're positioned usually just around the left subclavian artery, exchanged out for stiff wires. The sheath basically is the main body sheath is brought up from the left side, and you can see it's been positioned, and the contra sheath is brought up from the right side, and through that there's a pigtail catheter. Pigtail catheter is placed just above the renal arteries. You try to get a little below the SMA so it doesn't overlap, and the excluder really has been brought up into position. We're going to then shoot an arteriogram just to confirm the position of the lowest renal artery. That's what you really need to know. In this case, on the right side, there's not a significant amount of angulation. You then take the outer knob and rotate it basically to the left. That allows you to pull it and to deploy the main body down to the contralateral gate. And we've inserted as a panel the deployment sequence and what you do with these knobs. At that point in time, we then bring the pigtail down with the sheath to below the contralateral gate. You can see it's got that nice radiopaque marker. Typically we use a burn and a glide wire really to access that. In this case you can see that we chose to cross the limbs. That is done really based upon looking at the trajectory of the wires. Now it looks like the wire is inside this. Of course we then routinely advance the pigtail catheter, reform the peg and spin it, ensure that it's actually inside the device and not in parallel with the device. Once we've done that, we exchange out for a stiff wire, typically through the pigtail catheter. We used to always advance this is the spinning of the peg really, which has been demonstrated here, so we're pretty happy it's endoleaks. Then typically push the pigtail up and put in the stiff wire. Originally we used to always put the dilator back into the sheath and advance it up through the gate, but the limbs are so well attached now and the taper is nice that usually that's not necessary. It's certainly not wrong to do it, but you can avoid one step. Now what you're going to do is determine where the takeoff of the internal iliac artery is. Typically that's done by pulling the sheath down to below the internal iliac, injecting some diretrograde. You can see exactly where the takeoff is. That takeoff angle is defined usually in the CAT scan. Before we get into this, we actually have a little piece of paper taped onto the screen which shows you the angles for the lowest renal artery, the right internal, left internal. The appropriately sized limb is then brought up into position. You can see the radiopaque marker. Really what you're focused on is two things. Number one, getting optimal overlap, and then number two, positioning that distal marker. But in this case, the common iliac artery is so nice that you don't really need to be that accurate. At this point in time, the delivery system is then going to be removed. And you can see good technique. Someone's holding the sheath. It's pretty easy to actually pull these sheaths out, and that's just a real nuisance when it happens. To salvage that, you got to reinsert the dilator. Somebody's got to hold pressure, and then you got to put it back up. So just if someone gets a hold of the sheath, you can avoid something like that from happening. So once that iliac limb and the contra iliac is deployed, attention then turns to finishing off the deployment of the main body. Unfortunately, we managed to get the handle off the screen, so we will again insert the IFU from Gore, which shows the various different steps of use of the deployment handle in order to complete the deployment of the main body, detaching it from the delivery system and allowing you to remove the delivery system. And again, you can see, holding the sheath in place as your assistant removes the main body of the device. You can see the tip of that sheath right behind the lumbar spine hardware. That's a good place. And again, same thing, we injected retrograde, having moved the image intensifier into the optimal angle for the right internal iliac artery. Again, great planning, because you can see you couldn't get it much better than that. That then allows you to reinsert a pigtail marker catheter and determine what the length of the contra limb is that you're actually going to utilize. We're using an overlay. Now, what you don't see is that what we're looking at is left screen will have this overlay on it. Right screen, there's no overlay, so it lets you see the device a little bit easier than you can see it when you're using that overlay. Again, optimizing the overlap. The radiopate markers probably about a centimeter proximal internal iliac, and that's fine. You pull the string, it allows it to be deployed, holding the sheath to prevent it from being pulled out while the delivery system is removed. At this point in time, you're going to take a balloon. There's a variety of different types of balloon which can be utilized. I think this is the Gore balloon. You start off really in the proximal attachment system, so just below the renal arteries. There's no set pressure for this. You're going to bring it up till it squares off. Again, you can see that the operator is supporting that to prevent it from blowing down with the aortic pressure. And then you're going to deflate the balloon, always making sure it's completely deflated before you reposition it. And our routine is just to dilate up the entire iliac system. And once you've done the ipsilateral side, you're going to go over to the contralateral side. You don't have to do the proximal attachment system, but you got to do everything from the overlap of the contra limb all the way down to the distal end. So dilate the entire iliac system is what's going on here. Making sure you get the whole iliac. And you can see it's essentially positioned just a little right on top of the arrow mark. You got to be a little careful it doesn't extend beyond it, because this can be significantly oversized. And you deflate the balloon, take it out, holding the sheath again. Occasionally the balloon catches on it, tends to pull the sheath out, and then you do the same thing, overlap zone, and sequentially walk this balloon down on the right side. Now, while somebody is doing that, you should be loading up the marker catheter on the contralateral wire, positioning it up above the proximal attachment, just above the renal arteries. Allows you to move the case along fairly rapidly. In this case, both internal iliacs are in the circulations. We usually don't pull negative on syringes attached to the sheaths, but if there's any side that it is diseased or it's occluded, then you'll get static flow. And so our routine is to always check off right renal, left renal, right internal, left internal. I've actually missed an occlusion of a renal artery because I was so focused on a big endoleak that was occurring. And so make a routine just to check them all off. Thank you very much.